Alrighty. Good morning, everyone. Thank you for inviting me to speak at the International Conference on Microbiology and Infectious Diseases. My name is Priyanka, and today I'm going to be presenting on antibiotic prophylaxis used in oral and maxillofacial surgery. Surgical site infections are a complication of oral and maxillofacial procedures with the potential for significant morbidity and mortality. Surgical site infections are defined as those which occur within 30 days of surgical operations. The use of pre, peri, and post-operative antibiotic prophylaxis to reduce the incidence of surgical site infections must be balanced with consideration of a patient's risk of antibiotic-related adverse effects. This systematic review aims to provide evidence-based recommendations on antibiotic prophylaxis. 98 out of 280 retrieved papers were reviewed. The systematic review was assessed using AMSTER criteria, with RCTs assessed using Cochrane collaborative tools. The overall quality of evidence was assessed using GRADE. Firstly, I will go on to talk about extractions. Reviews were identified, screened, and assessed for eligibility. Approximately 31 studies were included in total. Of this, 14 Level 1 and 17 Level 2 studies were identified. No studies were found evaluating antibiotic prophylaxis for tooth extraction other than third molars. Prophylactic antibiotic use is considered based on the depth of impaction, need for osteotomy, trauma to the surrounding tissues, and post-operative inflammation. A clear lack of evidence regarding optimal timing of prophylaxis was evident. This review included 18 double-blinded placebo-controlled trials. Compared to placebo, antibiotic probably reduced the risk of infections in patients undergoing third molar extractions by approximately 70%. There is evidence that antibiotic prophylaxis may reduce the risk of dry socket by 38%. There is no evidence of a difference between antibiotics and placebo in the outcomes of fever, swelling, or trismus 7 days after tooth extraction. Antibiotics are associated with an increase in generally mild to transient adverse effects compared to placebos for every 21 people who received antibiotics. Of note, the 18 trials, only 5 of them had an unclear risk of bias and 13 had a high risk of bias, with none at low risk. These patients were healthy, undergoing extractions of impacted third molars, so no generalizability can be used with concomitant illnesses or patients with immunodeficiencies. However, patients at a high risk of infection are more likely to benefit from prophylactic antibiotics because infections in this group are likely to be more frequent, associated with more complications, and be difficult to treat. This review showed moderate evidence for the use of preoperative antibiotics and no evidence for the use of postoperative antibiotics in preventing complications when extracting third molars, and no clear evidence of the importance of the timing of antibiotic administration. I would then like to highlight a second article. Ramos et al. 2016 evaluated the type of antibiotics to reduce infection and alveolar osteitis. Penicillins had an increased efficacy than nitroamidazoles due to the limited activity against gram-positive bacteria. Markison performed a systematic review on the effect of single-dose preoperative antibiotics in third molars. He performed a meta-analysis of 10 trials showing a reduction in infection and alveolar osteitis with the use of antibiotics. However, the subgroup meta-analysis of 5 trials with low level of heterogeneity showed 2 grams of pre-op oral amoxicillin reduced the incidence of surgical site infections. The systematic review only addressed oral, not systemic antibiotics. I also just wanted to highlight the use of chlorhexidine mouthwash. Cho et al. In 2017 reviewed post-operative interventions to reduce inflammatory complications after third molar surgery. In relation to chlorhexidine mouthwash, highlighted articles including the Cochrane review by Daly, which included 21 trials. The authors found that Chlorhex mouthwash, both before and after extractions, prevented approximately 42% of alveolar osteitis. The number needed to treat with Chlorhex rinse to prevent one patient having alveolar osteitis was 232, 47, and 8 for control prevalences of alveolar osteitis of 1%, 5%, and 30% respectively. With respect to duration, Caso, Hedstrom, and Schrogen supported Chlorhex mouthwash used for 7 days postoperatively, significantly reduced alveolar osteitis. In summary, a single dose of pre-op antibiotics may reduce the risk of infection following surgical extractions of third molars. This should be balanced against the risk of antibiotic adverse effects and the potential for antibiotic resistance. If there is indication for systemic antibiotic prophylaxis, amoxicillin is the choice of antibiotic. There is lack of clear evidence regarding optimal timing of prophylaxis. I will now go on to talk about maxillofacial trauma. The decision to use antibiotic prophylaxis in maxillofacial trauma depends on the type of fracture, its planned treatment, for example, open versus closed reductions, and the location of the fracture. Antibiotic prophylaxis in this setting is thought to act against bacteria that enter the wound prior to surgery. 15 relevant studies were included. Andreessen's systematic analysis identified a significant reduction in infection rates with the use of preoperative antibiotics in patients with mandible fractures. Post-op antibiotic use greater than 24 hours for mandible fractures showed no significant benefit. Pre- and post-operative antibiotics in upper and mid-facial trauma are not routinely recommended. This is also highlighted by the meta-analysis performed by Habib, showing that the use of post-operative antibiotics does not significantly reduce the incidence or likelihood of infection. Dental implants are widely used. Long-term, aesthetic treatment for patients with partially or completely edentulous jaws. Implant success rates following trauma, and especially after fractures occur in this mandible or maxillary region, show that there is a significant increase in infection risk. 19 relevant studies were included. Overall, the quality of evidence used of the prophylactic antibiotics in dental implant surgery is essentially moderate. There was a moderate level of evidence to suggest that preoperative prophylactic antibiotics reduce the risk of implant loss by 2%. However, included studies have variable risk of bias. Patients who smoked appear to be greater risk of infection. Therefore, prophylactic antibiotic use is probably not required for single implant placement in low-risk patients. Where prophylactic antibiotics are warranted, 2 grams of preoperative amoxicillin has been shown to provide the same reduction in the number of implant failures as 1 gram of preoperative amoxicillin, and an additional 2 days of postoperative course of this antibiotic. As the potential for antibiotic-related adverse events increase with the duration of exposure, preoperative dosing is recommended in this setting. Temporomandibular joint surgery was defined as including total joint replacements, arthrocentesis, arthroscopy, arthroplasty, a condylectomy, or autologous blood injections. Infections occur in approximately 1.5 to 4.5% of patients who undergo TMJ replacements or total joint replacements. National and international published literature indicate that these infections are most commonly caused by Staph aureus, S. epidermidis, Peptostreptococcus, and P. aeruginosa. Currently, there is no high level of evidence found for the use of prophylactic antibiotics in TMJ surgery. However, some authors suggest that preoperative IV antibiotic prophylaxis, starting within the first hour prior to surgery, does reduce the risk of surgical site infection. 4 relevant studies were included. Potential prophylactic antibiotics for TMJ replacement surgery, including peri-op use of cefazolin every 2 to 5 hours, clindamycin every 3 to 6 hours, or cefuroxime every 3 to 4 hours, or vancomycin every 6 to 12 hours. Therapeutic concentrations of IV antibiotics should be maintained until the time of surgical closure. Oral and maxillofacial pathology is a heterogeneous group of conditions with differences in the complexity of operation. Due to the diversity of extent of procedures, this review included papers focusing separately on clean and clean contaminated head and neck surgery. 8 relevant studies were included. The majority of studies supported preoperative prophylactic antibiotic therapy should be considered for patients undergoing oral and maxillofacial surgery who have a significant underlying condition or who are immunocompromised. Russell and Goldberg's systematic review was limited to 5 randomized controlled trials comparing various antibiotic regimens of cefazolin, cefepozone, cefotaxime, moxillotam, and clindamycin, but lacked a placebo. Thus, the underlying effects of prophylactic antibiotics cannot be determined. Despite this, Russell and Goldberg, as well as recent meta-analysis, suggest little evidence for antibiotic use beyond the first 24 hours. Recent systematic reviews and RCTs have noted that clindamycin prophylaxis alone may be inferior to other antibiotic therapies and a risk factor for surgical site infections. Further research is required to identify an effective alternative to clindamycin in penicillin-sensitive patients. According to Cruiser, benefits of antibiotic prophylaxis in clean head and neck surgery do not outweigh the risks of adverse effects, as surgical site infections occur in less than 1%. A meta-analysis by Arian found no significant reduction in surgical site infections for clean head and neck surgery with antibiotic prophylaxis, and an effective duration could not be determined. The recommendations are summarized in this table. In orthognathic surgery, this was defined as including reconstructive surgery, maxillomandibular advancement, and surgical correction of facial asymmetry. Clean and contaminated procedures would be expected to have a high infection rates in non-contaminated surgeries. 22 relevant publications were included. It appears that procedures in the mandible are at greater risk of post-operative infection compared to other maxillofacial procedures. Overall, the quality of evidence for prophylactic antibiotic use was low in this setting, and there was mixed results in studies with low risk of bias. One study reported a benefit of preoperative antibiotics in bimaxillary surgery, while another suggested no benefit following post-operative antibiotics. Of importance, Zeerveld conducted the only placebo-controlled trial, and this had to be ceased early due to a large difference in infection rates between treatment arms. Although the difference may be due to preoperative versus post-operative prophylaxis, a lack of consistency in the definition of infection between the Zeerveld and Tan et al. Studies may account for the differences in their findings. One study suggested preoperative antibiotics was beneficial in bilateral sagittal split osteotomies. A 2017 randomized controlled trial by Davis found that 3 days of post-op cefazolin and cephalaxin decreases surgical site infections compared to 1 day, with the number needed to treat of 10. The trial did not include a placebo group that received no antibiotic therapy. Further research on the use of pre- or post-operative prophylactic antibiotics for orthognathic surgery is required. A cleft lip and palate may develop during pregnancy and is repaired in stages of surgical treatment. There is limited data regarding antibiotic prophylaxis in the repair of cleft lip and palate surgery. No national or international evidence-based guidelines exist. The incidence of post-operative infection following cleft lip and palate surgery is 1.3%. Risks are primarily associated with the length of surgical operation time. A 2008 survey of cleft surgeons in the UK found a majority used antibiotic prophylaxis for cleft lips and a slight lower proportion used prophylaxis for a pair of a cleft palate. One randomized controlled trial was included, which examined post-operative antibiotic prophylaxis used for cleft lip palate surgery. All patients were given a single dose intraoperatively, and essentially patients within this group were monitored post-operatively. 5 days of post-op antibiotics in this group decreased the incidence of fistulas from 17.1 to 10.7%. However, a high percentage of patients were lost to follow-up. Wider applicability of the study results to a Western setting is questionable. Evidence of the use of antibiotic prophylaxis in medically compromised patients to prevent surgical site infections in oral and maxillofacial procedures is extremely limited. There is only one randomized control study that was included by LOPES, evaluating the prophylaxis in dental invasive procedures in patients undergoing cancer or solid organ transplant. Procedures included exodontia or periodontal scaling, root planning, and prophylaxis of amoxicillin as a single dose compared to 2 hours preoperatively. An additional dose, 8 hours postoperatively was included. Currently, no surgical site infections occurred in either of these groups. However, there is insufficient evidence to base our recommendations. In conclusion, prophylactic antibiotic use is recommended in surgical extractions of third molars, comminuted mandible fractures, and temporomandibular joint replacements, clean contaminated chewing removal, and complex implants. Prophylactic antibiotic use is not routinely recommended in upper or mid-face facial thirds. Further research is required to provide recommendations in orthognathic, cleft lip and palate, temporomandibular joint surgery, and maxillofacial surgical procedures in medically compromised patients. I'd now also just like to acknowledge my supervisor, Associate Professor Dieter Bauer, and the Royal Perth Hospital in Australia. Thank you very much.